Remember before COVID-19, when we could go to shows or celebrate in person or have family gatherings where the only worry was when someone was going to talk politics? Let's get back to that. Let's get vaccinated. COVID-19 vaccines are safe, effective, and free. Sure, we'll have to keep wearing masks for a while, but you know what? This is the start. Go to covid19.nj.gov/vaccine to register for your vaccination. Remember traveling somewhere? Anywhere? Yeah, let's get back to that.
Welcome to the COVID Ethics Series podcast, a conversation with leading experts about bioethical issues that have been exacerbated due to the COVID-19 pandemic. I'm Brian Pilkington, and I teach bioethics at Seton University and at the Hackensack Meridian School of Medicine. I moderate the COVID Ethics Series in cooperation with the IHS Library and IHS Student Life. This podcast is a spin-off collaboration with the IHS Library, where we'll have the opportunity to go deeper with the experts from our series. Thanks for joining our conversation. I now have the distinct pleasure of introducing Dr. Lydia Dugdale. Lydia Dugdale is the Dorothy L. and Daniel H. Silberberg Associate Professor of Medicine at Columbia University, Vagelos College of Physicians and Surgeons, where she also directs Columbia's Center for Clinical Medical Ethics. She is a primary care doctor and served on the front lines in this past spring, 2020, in the COVID outbreak in the city in which she and I both live. So I'm especially grateful for that. Her latest book, The Lost Art of Dying, which is an excellent book, draws on lessons from the mid-14th century bubonic plague outbreak to ask how we might live well in order to die well. Personal professional note, I'd like to say that for philosophically rich reflections on medicine and dying during the pandemic, I can think of no one better to speak with us than Dr. Lydia Dugdale. So I'll now turn things over to her and we'll get going with her presentation.
Wonderful. Thank you. But I'm so grateful to Provost Pastorini, to Dr. Floyd and Dr. Pinkleton for inviting me and hosting this event tonight. I'm really delighted to be with you. I'm going to be talking tonight, giving you almost completely new material. This is something that I've been thinking about a lot over the course of the pandemic and have not ever put together a talk on. So maybe you're slightly my guinea pigs tonight, but I look forward very much to the Q&A when we can talk and I can hear from you, your reflections and your thoughts on what I'm about to say. So during our very strange plague year of COVID-19, lonely dying occurred both in long-term care facilities, such as nursing homes, and in hospitals. Patients and colleagues and family members and friends have all died alone. And Dr. Floyd already shared with us from his own family. 5 months into the coronavirus pandemic, an elderly woman living in a nursing home had lost 20 pounds, and she had lost her ability to speak. Due to virus containment efforts, as we all know, she had been moved from room to room in the facility. During those moves, the nursing home had lost her hearing aid. Her family was not allowed to visit indoors or outdoors. And eventually they were able to stand at the window about 6 months in, but by then the patient had become hardly responsive. The matriarch of a large family, this is my 90-year-old great aunt, who lived independently and entertained many, many guests. She had her own home and she had a vibrant social life. In late December 2020, she developed a cough. Shortly after Christmas, her family persuaded her to go into the hospital. She was diagnosed with COVID-19 and hospitalized. She was never intubated, meaning she was never put on a breathing machine, but she was only permitted one phone call a day, curiously, and no visitors. She died alone 20 days later. In late February of 2021, my friend's 83-year-old mother died alone. She had been admitted with COVID-19 and intubated, put on the breathing machine, as you see here. By day 10, she was deteriorating. and she never recovered consciousness. Even when they tried to ease the sedation and in fact stopped the sedation altogether, she never recovered consciousness. And in the end, she was removed from life support and died alone. Her hospital also did not permit visitors. Stories such as these shed light on the public health tension between physical distancing on the one hand to mitigate virus spread and social isolation that intensifies loneliness and physical decline. In the United States, as we all know, hundreds of thousands of patients have died from COVID-19. And the majority, the data tells us, died in medical facilities that restricted visitors to varying degrees. Such restrictions were necessary early in the pandemic. Shortages of personal protective equipment, which we came to call PPE, and uncertainty about how the virus was spread prompted hospitals and long-term care facilities to lock their doors to outsiders. It made sense. But the tragic result was that far too many patients died alone. Now, it's difficult to say for sure how many died in isolation. That data just do not exist. The Centers for Medicare and Medicaid Services, CMS, maintained different visitor guidelines for hospitals as opposed to nursing homes. What's more, CMS did not mandate collection of nursing home COVID data until late May, as you can see here. So this is the CMS data compared with the CDC data, but we don't even start collecting until May 24th. That's the first full week that we have data. And as you'll all recall, it was that first 2 months of the pandemic, March and April, when large numbers of seniors, particularly those living in congregate settings such as nursing homes, died. And we know now, based on what the data show, that in that very first wave, older folks disproportionately died from COVID and died as a larger percentage than at any other wave throughout the pandemic. So while it is impossible to say for sure how many died without friends or family at the bedside, it is reasonable to estimate that the number is significant. Now, what I'd like to do in the next few slides is sort of march you through the visitor restrictions that were imposed, particularly on nursing homes by the Centers for Medicare and Medicaid Services, CMS. CMS regulates federally funded nursing homes, and it provides guidance to hospitals, but the recommendations made to hospitals, as I mentioned earlier, were slightly different, although they were largely of the same vein than what was suggested to nursing homes. So here we go. We start more than a year ago on March 10th of 2020. And this was when CMS announced its most aggressive measures to protect the residents of long-term care facilities. They recommended immediate restriction of all visitors, as well as volunteers and non-essential personnel. Now, who are the non-essential personnel? This would be the barbers or the beauticians that come in to do the hair of the residents. The only exception that CMS made in those early days was for what they called compassionate care visits. And compassionate care visits were generally understood at that time to mean if a patient was actively dying, then the family could come in, but at no other point could the family come in. Now, despite this recommendation, there were many nursing homes that still did not permit visitors, even for compassionate care visits. CMS also advised canceling all communal dining and all group activities. For the most part, many residents of extended care facilities were confined to their rooms for months. As the CMS administrator, Seema Verma, at the time put it, she said this: temporarily restricting visitors and non-essential workers will help reduce the risk of coronavirus spread in nursing homes, keeping residents safe. So note that word temporarily, all right? This was meant to be short term. Now on May 18th, the CMS issued nursing home phased reopening recommendations, but this did not go to the nursing home administrators. This information went to state and local officials. Okay, but it did make provision for how we might begin to open up nursing homes. And specifically, it gave these three phases, which you've probably heard of. But suffice it to say, phase 3 is the point at which visitors were permitted in. All right. But to move even from phase 1 to phase 2 required no increase in community cases and no new nursing home COVID case in 14 days. So a 14-day stretch, no increase in the community and no new COVID cases in the facility. What's more, these May 18 guidelines required adequate PPE. They required sufficient beds in the local hospitals, and they required no staff shortages. And I'll tell you that even as recently as last month, 20 to 25% of federally funded nursing homes continue to report staffing shortages. So essentially, these recommendations that nursing homes could work toward opening, toward permitting visitors, were impossible to obtain. And very few were able to actually comply to the extent that they could let visitors in. So we continue, right? We continue to September 17th of 2020. We're now a full 6 months after what CMS called their temporary visitor restrictions. Now in September, 6 months in, the CMS issues new guidance on visitation. This is specifically to nursing homes regarding visitors. And this memorandum, for the first time in 6 months, recognized that isolation is taking a toll on folks living in congregate living, specifically physical, emotional, and mental toll. Visitors, therefore, CMS says, must be permitted as long as, and again, it's this high bar, as long as facilities have no new onset of COVID cases in the previous 14 days, are not investigating potential outbreaks, and the county case positivity rate, so that is of all people tested in a community or in a county, 10% or fewer would permit visitors to the nursing home. But all of these criteria had to be met. Then CMS also in this September memorandum lays out very, very specific criteria for hygiene and to mitigate virus spread. And these are all the things that the rest of us have been doing for months and months and months, right? Face coverings, hand hygiene, social distancing, screening. So they also in September expanded the definition of compassionate care. And they said, look, compassionate care is not just the person who is dying, but it is anyone who is suffering in a sort of noticeable and extreme way from the isolation. Anyone who is having difficulty adapting to this new, this new normal, this new very strange way of life. Any of those residents should have been able to have compassionate care visits. But again, as we've seen, that doesn't always happen, and that didn't always happen. Now, this was good news. Most states adopted these September policies. However, think back to where we were in the fall of 2020. Things were getting colder. There was a lot of concern about Thanksgiving and then a Christmas winter holiday surge. There was concern about the uptick in travel. Thanksgiving was really the first time we had substantial travel since lockdown in March. And as winter approached and public health experts held their breath for this holiday coronavirus surge, few long-term care facilities were able to open their doors in a meaningful way to visitors. And this was either because of outbreaks within the facility or because the communities themselves exceeded that 10% case positivity rate. So then we get to December. And what happens in December? There's this glimmer of hope. You'll remember the FDA, the Food and Drug Administration, gives emergency use authorization to the Pfizer vaccine, and then a week later to the Moderna vaccine. And really across the bioethics world, there was widespread, and public policy world, there was widespread agreement that older adults in congregate settings, as well as frontline healthcare workers, really should be the first recipients of the vaccine. They should be prioritized. Still, many institutions did not welcome visitors, even in the weeks after vaccination, weeks to months. So I'll just give you a few examples. A colleague of mine wished to visit his mother at her nursing home, a 3-hour drive to visit her. And this was January of 2021. She'd been vaccinated. He was told he could have a 30-minute slot at the window, and then that was all. Because of staff shortages, they did not have people to wheel the elderly residents or the disabled residents to the windows. And so he was only permitted 30 minutes. And the rehabilitation facilities would not permit visitors. And so we would have all the discharge work ready to go, all of the preparations made, the best laid plans, and the families would refuse discharge because even though they could visit in the hospital, they could not visit at the rehab facility, and they did not want their loved one, their family member, someone who'd just been hospitalized for months, to be discharged to a place where they could not visit. So this became a very real problem for us. And then I'll just give you one more story, which is another family member of mine, elderly uncle, went into the hospital on New Year's Eve with very, very real medical problems, quite severe. He was hospitalized for several weeks. None of the family could visit. And then because he was so deconditioned and weakened from the hospital stay, he was discharged to a rehabilitation facility for about a month. And the only thing that family could do was stand outside the window and wave. So really, my own uncle, again, 7 weeks of complete isolation and no ability really to meaningfully interact with family members. And this, again, is after vaccination, and it is after the guidelines that say we need to be opening up and permitting visitors. So that brings us to March 10th of 2021, a full 12 months since issuing its first stringent visitor restrictions. CMS finally revises the policy to account for, they say, the widespread vaccine distribution. And this makes sense. And in fact, when most of the nursing homes had at least had access to vaccine in the first weeks, there were many of us who were saying, we need to open up, we need to open up. Here in New York City, people were allowed to have indoor dining, but folks living in nursing homes who had had no visitors for a year could not have visitors. So the March 10th guidelines were much, much anticipated. And this is what the policy noted. They said that facilities should allow indoor visitation at all times and for all residents, regardless of their vaccination status, except when the resident has an active COVID infection, makes sense, or the resident is actively being quarantined because of exposure, makes sense, or if COVID is just going crazy in the community. So if it exceeds that 10% and the vaccination rate of the residents of the facility is less than 70%. So that's a lot of numbers I just threw at you. But basically, they're saying anyone at any time should be allowed to have visitors unless COVID is so bad in the community and the residents on the whole are not vaccinated. Okay, so that was the updated guideline. And it continued to make provision for compassionate care visits, of course, as well as explicitly stated that there is a federal disability rights law that requires that visitors be permitted for folks living with disabilities. And this was something that hadn't come up in the earlier guidelines. So it was interesting that it was finally made it into the guidelines, which it was already codified in law, but it probably took some lawsuit to get that in there. I'm not sure. I'm actually not sure how that got in. But the other thing I just want to note is that CMS also finally humanized their language. So all of these, memoranda had been very governmental regulatory. It had been full of governmental regulatory language. But finally, in this March 10th memo, they go beyond a mere recognition of the, emotional and physical toll. And they say this, keep in mind, this is coming from the federal government, but I think it's so interesting. We also acknowledge that there is no substitute for physical contact, such as the warm embrace between a resident and their loved one. Therefore, if the resident is fully vaccinated, they can choose to have close contact, including touch, with their visitor, despite the government's clear exhortation to permit visitors and hand-holding and human touch. Many nursing homes still continue to struggle to strike that balance between the requirements for testing and the imposition of isolation on elders and people living with disabilities. So there's a group called the Empire State Bioethics Consortium, of which I'm a member, And it's a group of bioethicists representing New York State that convened about a year ago and continues to meet biweekly. And a subset of our group published this just last week in the Hastings Center blog. Hastings Center is a bioethics think tank. This is what they say. They say it's common for nursing homes to identify asymptomatic cases through routine testing of staff. In New York State, where routine testing is conducted twice weekly, these cases of COVID arise frequently. And with each positive test, the nursing homes must suspend visitation for a period of time and place for at least 14 days. Now, they say, in an excess of caution, health authorities sometimes require the facility to confine not only residents of affected units, which is what the most recent directives call for, but all residents to their rooms every time a positive case is identified. So again, this excess of caution ends up isolating the elderly, assigning them to a fate that sometimes feels worse than death itself. And in fact, we have that kind of language on record. And so I'm going to share some of that with you. So what I'm telling you then is that the problem is not just dying alone. It's also the process of lonely dying. There's a group called Alterum. It's a nonprofit research and advocacy group for nursing home residents. And it conducted an online survey in July and August of 2020. And it asked nursing home residents specifically to describe their extreme isolation due to COVID-19, to describe their experiences. What's it been like? Now, you have to keep in mind that the people who answered this are nursing home residents who not only have access to a computer, but the facility to manipulate the computer, as well as the ability to type and provide a coherent answer. But this is what we learned from that survey data. About 10% said before the coronavirus restrictions went into place, they had no visitors. That's the royal blue on these graphs. 10% of nursing home residents had no visitors prior to the pandemic. This in and of itself would be a tragedy. 1 in 10 of our seniors, and remember, it's not just seniors, it's also people living with disabilities who are also nursing home bound. 1 in 10 does not have visitors. But then look at this after, on the right-hand side, after the coronavirus restrictions go into place, nearly 72% of respondents reported no visitors, 72. And remember, this survey was conducted 4 and 5 months into the lockdown. 64% reported they no longer left their rooms to socialize, and 76% reported a surge of loneliness. The residents reported that isolation from family and friends had taken a toll on their health. These are some of the quotations. "I've been restricted to my room so long, my life has gotten worse," said one. "No visitors, no going out, no nothing." There's another woman who lived in the same facility as her spouse, and she had not been allowed to see her husband for more than 100 days. She wrote, "The facility needs to create a safe way for me to see my spouse and not keep me locked up in my tiny room. Hopefully, I won't die from the way I'm now being treated." Others shared those sentiments. One person said, "If the virus doesn't kill me, the loneliness will." Somebody else said, "I'm completely isolated. I might as well be buried already." People reported weight loss. One person said that he had lost 40 pounds. The point of all of these quotations, and there are hundreds more, is that separation from family and friends and loved ones was killing these residents. And we know that there's no question that loneliness aggravates sickness. The Centers for Disease Control describe loneliness and social isolation as serious public health risks. That's the language the CDC uses, serious public health risks affecting a large proportion of older adults. Indeed, social isolation is associated with a 50% increased risk of dementia, 32% increased risk of stroke, and a 29% increased risk of heart disease. but lonely living also hastens death itself. In a 2020 report, the National Academies of Science, Engineering, and Medicine considered more than 40 years of data and concluded that social isolation is accompanied by significantly increased risk for premature mortality. So to sort of take all of their data together, we see that loneliness independent of depression is associated with a 22 to 26% increased risk of death. So to put it bluntly, loneliness kills. Now, the tricky thing about the COVID-19 pandemic is that in our efforts to thwart disease spread, we have caused a different kind of malady. I'm drawn to the problem of forced social isolation during the pandemic, in part because for years now, I have had this longstanding interest in how people might die better. And you've already, the book has already been mentioned, but this is my most recent book that as Brian said, riffs in a way off of the bubonic plague of the mid-14th century to ask how we might live better in order to die better. So I'm just going to briefly tell you about this, but then I want to make sure we talk about what we could do about this problem. So here you are. This is actually an image from an illuminated manuscript from the mid 1300s, which is when the bubonic plague swept through Western Europe, moving from the east to the west. The plague was transmitted by rats and fleas. The fleas would bite the rats would bite the humans would get sick. It tended to concentrate in crowded urban areas because that's where the rats were drawn, right? They came to the people and the trash and the debris. And so crowded urban settings tended to have a disproportionate share of the disease. We know what we know about this mid-1300s outbreak of bubonic plague, also called Black Death, because of this guy, Giovanni Boccaccio. And for those of you with a strong humanities background, you may have read the Decameron. His book, The Decameron, is a series of stories that a group of friends told one another as they escaped from Florence during the plague and went to the countryside villa to sort of get away from all of the death. But in the introduction to the Decameron, Boccaccio well describes what it was like to be in Florence as the plague struck. Historians tell us that perhaps as many as 2/3 of Western Europeans died. I'm just going to briefly show you this etching. You can see at the bottom in Latin, it says the plague of Florence as described by Boccaccio. So this is an etching done by an Italian artist, Luigi Sabatelli, probably in the early 1800s. But what we see here is we are outside the walls of Florence, and there is a massive heap of dead bodies in the center, slightly to the right, that are awaiting burial. In the background, you can see men with hoods and pickaxes, presumably hiring themselves out to bury the dead. There's probably a priest in the background waving incense, perhaps a general benediction for all of those bodies. And then in the foreground on the left, there's a man holding this book, and you'll recognize him from this previous image. It's actually Giovanni Boccaccio himself that Sabatelli put into the etching. And there's some speculation that perhaps he's holding a copy of Dante's Inferno. I show you this to sort of paint this picture of mass death and how much chaos it brought to what may have been otherwise a relatively predictable or more ordered life. And I tell you that because I want us to reflect on what we have been through in this last year, and particularly how we have treated the sick and dying. And what Boccaccio says about Florence in the mid-1300s during plague outbreak is that people behaved in surprising ways. There tended to be three groups of people that emerged during the bubonic plague outbreak. There were those who holed themselves up as hermits in their homes, permitting no one to enter or exit. and they ate and drank in moderation. They were afraid of inviting divine retribution for any reason. And then the second group were those who, in recognizing that death was imminent, indulged in total hedonism. They went to taverns. For many of the wealthy who fled the cities to their countryside villas, or those who died, these pleasure seekers would ransack their homes, stealing and taking what they wanted. Perhaps we might think of this as the Miami spring breakers. I don't know. That's probably not fair, but there's this way in which the threat of death can make us just want to live as wildly and fully as possible, a sort of carpe diem mentality. And then there's this third group that takes the middle road. They didn't lock themselves up and they didn't indulge their passions, but they would go for strolls about town, carrying flowers or sweet smelling herbs. And they'd hold those up to their noses, Boccaccio says, to fortify the brain against the stinking air that seemed to be saturated with the stench of dead bodies and disease and medicine. So those are the three groups that Boccaccio describes. But beyond this, death itself caused people to behave in unexpected ways. Perhaps it was the desperation to save oneself, but family members would abandon their own sick. Parents deserted their children. Wives left their husbands, which again, in the late Middle Ages would have been completely, completely crazy to do. And if servants remained to care for their dying masters, if they were sort of remained loyal, they then sacrificed their lives in the effort. So I tell you this, I sort of pull in this history to highlight how death and pandemic do make us behave in bizarre ways. When we're confronted with death on a scale we've never seen before, there's a sort of collective dysfunction, sort of panic mode of wanting to mitigate death and thwart death and protect ourselves, and families break down and communities break down. We saw that in the mid-1300s. But what's interesting about this particular outbreak is that for those who survived, which could very well have been the minority of the population, they recognized that they needed to do things differently. So they knew that it was a given that plague would return, or if not plague, there would be famine or there would be war that would claim large numbers of lives. And so they needed to be ready. And as I describe in the book, and I'll just mention briefly here, this led to the birth of a genre of literature known collectively as the Ars Moriendi, which is Latin for the art of dying. These essentially were handbooks on the preparation for death. The earliest iterations emerged from the church. We think that that's probably at the Council of Constance in the early 1400s, which meant to resolve the problem of multiple popes. That's probably what led to the distribution of the first set of handbooks, but there were many subsequent iterations, adapted and adopted for cultures, different languages, different religious and even non-religious groups. There was also an illustrated version, which is where these illustrations are taken from, that was developed so that the uneducated or semi-literate could also study the images, anticipate, and prepare for death. The idea was that that living well and dying well are so closely related. But what's fundamental to both living and dying well, and indeed the commonality through all of this genre of literature, is that both are done in the context of community. That to live well in order to die well, we need to live with a view to the end, with an acknowledgement of our finitude, but to work out the good living and good dying within the context of community. Another way that it was described was as a great drama where everyone had a role to play. So in the face of this massive loss of life, mid-14th century Europeans recognized that community is integral to living and dying well. And these handbooks empowered them to think through this together. And reflecting on this, then, the question for us is the same. In the wake of substantial loss of life from COVID-19 and the very real potential for another wave or even another pandemic, what do we do differently? And what should remain the same? So I mentioned this group, the Empire State Bioethics Commission, Consortium rather. And in their piece that I described some of it earlier, they also wrote this. They said, infection control measures that restrict the liberty of residents require robust ethical justification. They go on to say policies intended to reduce the risk of harm must not cause secondary harms that cumulatively are disproportionate to the realized benefits of risk reduction. So don't make the treatment worse than the disease, right, is what they're saying. But they're calling for ethical justification. And the question then for us in this ethics talk on COVID is, what is the correct ethical approach for navigating the middle ground? And so I was thinking about this, and that kind of drove me back to ancient Greece, right? We know that the ancient Greeks were consumed by the idea of the good life and the ultimate purpose of human existence. The word in Greek that they used was eudaimonia, which is often interpreted as happiness, but it's really so much more than happiness. It's not a fleeting happiness. What the Greeks thought the good life was about was this robust notion of human flourishing. It was sort of living life in its fullness, but the way to do that was to cultivate a life of virtue. One of the things the Greeks said is that we study ethics in order to improve our lives. For both Plato and Aristotle, pictured here, cultivation of a life of virtue is indispensable to the well-lived life. It's the virtue, it's the cultivation of virtue, the practice, the habituation to a life of virtue that leads to flourishing. But here's the tricky thing, okay? Here's the tricky thing about Aristotle in particular. He did not believe that everyone could flourish, that everyone could achieve the good life. In fact, he makes it clear that in order to flourish, a man, first of all, you had to be a man, but a man must possess other goods as well. And those goods include friends, wealth, and power. So on Aristotle's accounting, one's flourishing or happiness, this, more robust version of happiness, this flourishing, is endangered if, for example, you are lacking in certain advantages. So Aristotle says, if you're really ugly, if your children or your good friends have died, if you're poor, if you're weak, all of these things threaten the possibility of a life of virtue, and they threaten the possibility of flourishing. Aristotle would say that lacking these other goods, right? So someone who is friendless, childless, powerless, weak, and ugly, such a person will simply not be able to find many opportunities for virtuous activity over a long period of time. And what little he can accomplish will not be of great merit. And so, he's just not going to get there. But if this vision of the good life on Aristotle's accounting is not available to the powerless, it needs to give us pause. It certainly means that this accounting is insufficient for our purposes. But again, when we're thinking about COVID, plague, how to care well for the sick and the vulnerable, how to mitigate disease spread, but also encourage community and relationship and embrace and touch, then we need to think differently about virtue, and specifically the virtue of justice with regard to power, right? So Aristotle wants power in order to have the flourishing life. We're talking about the powerless. So that's where I'm going to pivot to the French philosopher and mystic Simone Weil. And she says this, which is so interesting to me. She says, love of neighbor and justice are one and the same. And that, in light of everything in the last year, not least the Black Lives Matter protests, for all of the ways that justice has been thrown around or used as a prop or used legitimately, to think of justice as love of neighbor sort of upsets it all, right? It pushes us to a higher standard. it forces us to think about virtue. And so Simone Weil goes on to say this. She says, when two human beings have to settle something and neither has the power to impose anything on the other, they have to come to an understanding. Justice alone has the power to make two wills coincide. Okay, so she's saying we have two people, equal footing, equal power. They don't agree, but they have to come to an understanding. Justice is what makes them, their wills coincide, is the language she uses. Okay, why justice? Because it's love of neighbor. Why is it that you choose to agree with someone? You choose to compromise, you choose to meet them halfway, or you even go all the way, and right? Why is it that you do that? It's love of neighbor. So she says, again, justice alone has the power to make two wills coincide. She goes on to say this, but when there is a strong and a weak, there is no need to unite their wills. There is only one will, that of the strong. The weak obeys. All right. So now she's juxtaposing it with the strong and the weak. That is our situation with public health experts and CMS administrators and the sick and the dying in nursing facilities and hospitals. All right. There's only one will, and that's the will of the strong. The weak has no point, no possibility of dissenting here. And there's I'll put an asterisk there, and maybe we'll get to it in the Q&A. But then this is what Simone Weil goes on to say, and I think this is really, really worth taking note of. She says, the supernatural virtue of justice consists of behaving exactly as though there were equality when one is the stronger in an unequal relationship. Again, this is a way that I think it completely turns on its head this idea of justice. Behaving exactly as though there were equality when one is the stronger in an unequal relationship. Again, we're getting at love of neighbor. Now, Simone Weil regards as preposterous the idea that the cultivation of virtue is limited by position, gender, health, or sickness. She's certainly a woman, and she also suffered from sickness throughout her life. But she did not feel limited by that in the sense of morally limited, right? The cultivation of virtue was still very much a possibility for her. In fact, true virtue, true justice requires the strong to regard the weak as equals and to make their wills coincide. So when we bring this back to the problem of lonely dying and dying alone, of hospital policy in COVID, of bubonic plague, and how the threat of death makes us behave irrationally or erratically or unpredictably, and how in the aftermath of plague, we need to reimagine community life. Let me say this. When residents of long-term care facilities ask to see their spouses or their family members, or ask to leave the facility to sit in the garden, or even to visit their grandchildren, those making policy must ask themselves whether they too would want the same goods after months of isolation, right? How can they, the stronger, regard the weaker with equality in that unequal relationship, to go back to Simone Weil? So if the answer is yes to these questions of, do you want to visit family members? Do you want to sit in the garden? If the answer is yes to public health experts and CMS administrators, and of course it would be yes, then we need to figure out how to pursue human flourishing, not just for the strong, but also for the weak. So I'm going to stop my slides and just end with a few very tentative proposals, and then I look forward to the Q&A. So here are just a few very, very basic, and you'll probably say this is so obvious, but let me start with this. First, let's recognize that relationship is essential for the good life, even in a pandemic. Living and dying are community affairs, and this means that no one can or should ever live or die alone. right? This isn't just calling on clinicians to stand in the gap. That's one of the solutions that's been proposed. Doctors and nurses, now that you've been vaccinated, go sit at the bedside of the dying patients who can't have their family there. That's important, and doctors and nurses should be doing that and actually have been, but that's not enough. Recognizing that relationship is essential for the good life means welcoming family and friends at their own risk, at the risk of the residents, because it is right to experience sickness and dying in the context of community. Second point I'll make is that we should overstock PPE at hospitals and nursing homes so that they can open their doors to visitors regardless of the pandemic. Now, you might think this is old news, but as recently as last month, 10% of nursing homes reported that they do not have enough PPE to last a week, which means that many facilities are sort of flying by the seat of their pants one day to the next. And you can understand that those facilities would not be wanting to use their precious PPE for lots of visitors. It's amazing to me that more than 1 year into the pandemic, we're still fighting for face masks and paper gowns in 10% of our nursing facilities. And the third point, this is sort of pushing us. We start with relationship, living and dying in community. We push out to some very basic measures we can institute in our facilities. Let's just get that PPE. But the third point is consider appointing a cabinet member on loneliness. I shared with you the data. 10% of residents of nursing homes had no visitors prior to the pandemic. And obviously the pandemic's made it worse. 72% have no visitors. The Surgeon General of the United States, Vivek Murthy, has written a book called Together, documenting, he wrote the book prior to the pandemic, finished it during the pandemic, but documenting the problem of loneliness and isolation in the United States. We could look to what the UK has done. In 2018, Prime Minister Theresa May appointed the UK's first national strategy on loneliness. Some people call it the Ministry on Loneliness. And actually just earlier this year, a couple of months ago, Japan appointed a Minister of Loneliness. The US might do the same thing. And clearly on all of these issues, we've got a lot of work to do. I thank you for your time and I look forward to your questions.
Professor Dugdale, thank you so much for a wonderful discussion. The breadth from the medical details all the way through the virtues, Aristotle and Plato. That was excellent and thought-provoking. So I now will take up my role as the moderator, which is an unenviable one because we got a bunch of questions ahead of time. And you have a really nice image, a challenging image in the book about the conveyor belt, right? And sort of conveyor belt moving on and on. And it struck me that in what you're speaking about tonight, there's still a kind of efficiency that lots of folks look to, many of us look to respond to COVID. And I'm curious, maybe if you really just an invitation for reflection, because I can link, but I'm thinking about the connection between that sort of utilitarian mindset and bureaucratic rationality, and any reflections you have, if you have a cure for this or a response, that would be super helpful.
So the conveyor belt that I describe is something that other physicians have written about, but I describe it because I talk about dying well. And the conveyor belt specifically comes to the fore when we start approaching, the end of life, which we can't always anticipate. But the conveyor belt thing would be like this, grandmother falls and injures her hip. When she's in the emergency room, they do a chest x-ray because they want to make sure she didn't fall because she's getting sick with a pneumonia. They also, check her blood cultures and check her urine to make sure it's not a urinary tract infection, things that can be invisible in an older person. And then when they do that x-ray, they find a spot on the lung. Now, even though Granny's quite elderly and lung spots are very, very common and often not cancer, now you're starting to proceed with the next level. So now you're ordering a CAT scan. You're getting more imaging of the chest. The CAT scan comes back on the fence. Is it a lung cancer? Is it not? We're not sure. Let's get tissue. Now Granny's going in for a biopsy of her lung, which leads to, something goes wrong and now she has to have a chest tube placed. Then she ends up getting a pneumonia. And you can see how this goes, right? So we're sort of like one thing begets another thing begets another, and we can't get off. When do we say enough is enough? And in the book, I really call on people to press their physicians for answers. Ask for answers. Ask questions until you understand. Ask for data. Ask for prognosis. Doctors are horrible prognosticators, but there's no reason you can't ask. Try to get a sense of how this particular situation lines up in the big picture. I also talk in the last chapter of the book about frailty, which I think is probably one of the most effective ways of getting a sense of whether we should encourage our ailing or elderly family members and friends to proceed with aggressive interventions in the hospital. But there's some great tips and tricks for getting a good sense of whether someone is frail. And then when you do that, you know, well, wow, if they're really this frail, then we probably shouldn't proceed, because the likelihood of things going wrong and leading to that conveyor belt is greater. Now, what's interesting about the COVID pandemic is that the conveyor belt, the conveyor belt kind of showed up, but not in that same way I just described. So with COVID, our hospitals quickly became filled with one disease because everybody else stayed away, even to the detriment of their health. And people often turned the corner quickly and then went home, or they got very, 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 very sick. In the very, very, very sick, then it was possible for lots of things, the kind of domino effect of lots of things to go wrong. But that was all related to one disease. It wasn't, we found this and now we found that, now we're doing this, and then there was that side effect and now we're in this situation. That's very different. There were lots of things that would go wrong, but it was all related to the same disease. So the conveyor belt showed up slightly differently. When you talked about like a utilitarian calculus and COVID, it's funny. So I feel like a lot of non-physicians, especially bioethicists and philosophers, have taken physicians to task over what sounds like this kind of cold utilitarian calculus and the way that we would, for example, assign ventilators, right? That was the big thing a year ago. Granddad's not going to get the vent because the 27-year-old father of two, we're not going to give the vent to someone who's dying because we want to save it for someone we want to give it. It's not save it. We were never saving much equipment. We were using everything we had. The counter is, do you, in a sense, use the technology or the interventions knowing that there's almost 100% chance they won't work in certain people, at risk of seeing other people who definitely have a much higher chance at living, seeing them die? And so an analogy to this is organ transplantation, right? We have very limited organs, and the transplant surgeons and the transplant teams are very careful to really pick apart who should get those organs. It's not a determination of social worth. It's not that we like this guy more than this guy, or this guy's got a higher education than this. It's not about that. It's about who has the kind of really the community in place, the social resources in place to be able to remember to take all of their medications so that their body doesn't reject the organ. So, I wouldn't call it a cold utilitarian calculus. I would think of it more as, how can we use what limited resources we have to help the most people and to see the most people possible flourish? And so I think that's probably the way I would push you to frame it.
Thank you. That's super helpful. And I appreciate your indulgence of my 4 questions disguised as one. So we've had a question submitted, and I'll read it to you. It seems like it's, and there are a number of questions around this theme. It's almost a post-mortem in light of your current reflections on what might have been done. So the questioner asks, at the height of the pandemic in New York City, when systems were overwhelmed, staff were getting sick, bed and staff shortages were severe, and PPE was inadequate, could there have been any way to allow family to be with dying patients? I know there are physicians who feel it was a mistake to not allow at least one family member to be with a dying patient, but was it simply impossible?
So this is where different hospitals had different experiences. I work at Columbia University's kind of mothership hospital, and I will say that we were very cautious with our PPE. I would say we reused PPE, meaning that we would have the same mask on all day. I would usually save my N95 and use it again like a week later. So all the virus on it would die, and I'd hang it up in my office. So, I was we were really careful. At the same time, did we ever run out where there just wasn't anything? No, but we all saw in the news that there were hospitals that did, right? There were hospitals where people were bringing in rain jackets to wear for, there's different things like that. So, I guess the other thing, though, that in the early days, we weren't entirely sure how it was spread. I mean, we knew it was a respiratory virus, but could it go through a cloth mask? Could it go through an N95? How much would it spread? How much could it be spread by human touch, right? So sometimes when I give talks on more on the book, which this one wasn't, I show pictures of what the dress was like for the doctors during the bubonic plague and how that compares to the PPE that we use now. And really this kind of, when you don't know, you go head to toe, right? You just cover up. It strikes me as, I would say, probably in the first 2 months of the pandemic, we were so overwhelmed in New York City in a kind of controlled way, but it was bad. It would have been hard to imagine lots of visitors. Do I wish we would have had some? Yeah, especially for the dying. I mean, this breaks my heart. This is the thing. I think the fact that so many people have died alone is going to be one of the greatest tragedies of this pandemic.
Thank you. That's really helpful. And a quick follow-up to that, in light of your current discussion and thinking about folks in nursing homes who have been sort of physically and socially distanced, could you, because there's some questions sort of asking about this, could you say a little more about that and why you think that might be the case? I mean, is it fear, which you talk about really nicely in the book, and sort of an over-medicalization of certain kinds of things? I mean, why, given that physical contact is so important, why is it or why was it that we did this? Why are these policies in place?
Yeah, I mean, the policy should have gone away, I would say, within a couple of months. But then it's interesting. I mean, we've learned a lot, and I think I've been enormously humbled by this pandemic to the point where I stopped predicting anything. I mean, and I think we, doctors kind of we like to look at the data, and we like to try to say, and all of our family and friends, they ask us, well, what do you think? What do you think? And then we sort of try to figure it out. But I mean, we've been wrong and wrong and wrong and wrong. And, India was getting better in February, and now it is completely out of control. It's devastating. Why was it getting better in February to the point where Indian officials thought that they were going to dodge another surge? And now it is just completely awful. And, the question of the variants and new variants, and are we in the home stretch, or is next winter going to get bad again? None of us can say. None of us can say. All you need is a mutation that renders the vaccine completely ineffective, and then it's back. So when we think about visitor policies, once we had enough PPE, I work in the hospital. I'm taking care of patients with COVID. I'm in their faces. I'm listening to their lungs. I'm adjusting their, suctioning out their mouths. I am completely immersed in COVID virus, but I'm also completely covered in PPE. And I'm talking about pre-vaccination, right? So the PPE is effective. And so once we had sufficient supplies, I really think there's, no reason that people should have died alone. there's a part of me that, would say personally, I would rather risk my own health than to have my child or my spouse or my parents die alone, right? But that risk would require an imposition on the facility, which is trying to kind of mitigate spread for everyone. So it does get tricky. I mean, I recognize that any risk I might be willing to take personally doesn't necessarily translate into a tenable policy for an institution.
Thank you. And this is perfect because there's another sort of cluster of questions that came in earlier asking about policies. So as someone working on the front lines, as someone who's sort of philosophically and deeply reflecting about these issues, who would you suggest, or what kind of groups are we thinking about? Boards? Are we thinking about physicians, healthcare practitioners, lowly citizens who do a little philosophy? I mean, who should be involved in thinking about avoiding the next PPE shortage? Is this a board planning issue? I mean, just in sort of, because you make that great point. We see, or at least some see, as things do get better in certain places, as there are success with vaccines, more and more of the, you had a nice metaphor of the spring break, right? More and more of that kind of sentiment. And, so who knows, maybe there's another spike, another variant. Who should we be looking to sort of do that kind of planning?
Yeah, early on in the pandemic, I had a friend who works for Goldman Sachs contact me, and like Goldman Sachs was going to get the PPE for my hospital. And I was grateful, I was grateful for the effort, but I do think that, so it's interesting. I mean, on one hand, it's all hands on deck, right? This is a public health emergency, all hands on deck, everyone do their part. I love the stories of the third graders sewing masks that, made it through the news and things. But from a policy perspective, it struck me quite early that we know, so just looking back on the last 20 years, we've had H1N1, we've had the first SARS, and we've had something called MERS, Middle Eastern Respiratory something. We've had several of these now. The other ones, there was sort of excitement and then they died out. This one, excitement, and we all said, oh, here we go again. I mean, some of us said, oh, here we go again. This is going to be not that big of a deal. It's going to die out again, and it didn't. So it struck me when we were talking about PPE early in the pandemic, and this has continued to be a refrain. I told you 10% of nursing homes still don't even have 1 week supply of PPE as of last month, that the United States government really should secure its production lines. And I'm not quite sure how that happens. That's outside of my sort of expertise for sure. But that seems like something I know the US government did persuade, for example, the Scotch tape maker, what is it, M3 or something, 3M. They also make N95s, but to sort of switch their production to N95s. So I think to fund certain manufacturers to be ready to pivot for times of crisis. And we do the same thing with the US military, right? We can pivot for times of crisis to sort of rev up production of certain equipment. I think if this pandemic has taught us anything, it's that some basic protective gear, we should be able to increase production domestically. We should have the supplies, the raw materials on hand domestically to be able to address these needs. Same thing with mechanical ventilators, which I know the federal government has a stockpile of and has been using, but to sort of readdress that, kind of take stock literally of the stockpile, see how much we have, what we need, and then anticipate based on what we've learned. It would be a real shame if after all of this, we don't go back and figure out what we learned from it. And I think that there's a way. I often like to talk about the 1918 to 1920 flu pandemic, because almost nothing has been written on that. And the reason why, especially immediately in the decades immediately following, is because people were so sick of death going from World War I, 1914 to 1918, overlapping with a flu pandemic worldwide, 1918 to 1920. They were so sick of those 6 years of death that when you get to the roaring 20s, economic investment, the economy's booming, everyone's building. The last thing you want to do is take stock of 6 years of death. right? You just want to forget it. And my gut feeling is that there are a lot of people who want to forget the last year as quickly as possible.
Yeah, that's really helpful. And it might be in all of this, right, with our bioethicists' hats on, that the principle of the duty to plan, right, is the sort of the key principle coming out of this, as opposed to some others. I want to shift back a bit to some of the nursing home conversation, given some of the questions that are coming in, and also sort of preparing for death in the right sorts of ways, and also preparing for life. So we have a wonderful College of Nursing at Seton Hall, and my nursing colleagues have been really helpful in shedding light for me. I mean, there's something there's something they know, but about the generally low resourced nursing homes across the U.S. So, and they've told me time and time again, look, we're behind. We need more and more nurses. We need more and more care in nursing homes. So here's a big question you might take a crack at. Culturally or sociopolitically, have we distanced older folks and folks in nursing homes in a way that the sort of policies which have kept them separated from other folks isn't really a new problem, but it's a symptom or an incident? Or could you reflect, sort of help us think through, and especially the nursing colleagues who are writing in now, they've seen certain sorts of things, not these kinds of policies, but other sorts of sort of failures. So any thoughts on that?
Yeah, I mean, the very quick response is, I mean, there's a reason why, as a primary care doctor, so many of my aging baby boomer patients say to me, I never want to be in a nursing home. No way, no how. And in fact, actually, then it pushes to assisted suicide, right? So I would rather end my life on my own terms than linger in a nursing home like I've seen X, Y, and Z. So, and it's not fair to say that that's the case for all nursing homes. And it's certainly not fair to at all denigrate those who work in nursing homes as if it's their problem. Because as you say, it's often a problem of staffing and resources. And just like we don't want to fund elementary school education or preschools, right? We don't pay our teachers well, at the beginning of life. We don't pay our babysitters well. We don't pay caregivers to the sick and dying well either. So yeah, there is a systemic problem there. I don't have a great solution. I'm sorry.
Oh, no, not. I mean, I'm culling all of the questions that are coming in, but we're really giving the ones that are tough and have a punch. So we are running a little bit low on time, so I'm going to give the couple of last questions, and then everyone, we're going to pause, and we'll have some announcements to share. So the last few questions I want to offer from, we've had a few questions come in from students. We have a great medical school at Hackensack Meridian, a great school of health and medical sciences at Seton Hall, along with our great college of nursing. So we've got nursing students, health profession students, and also future medical students. So I was curious, in light of what you've said about community, you've done a lot of work in your career around the notions of community. And one that you mention in the book is the sort of biomedical community. So in light of what's going on in COVID, in light of the sort of lack of physical interactions, I mean, you've noted, sorry, this is turning into one of my really long questions. You've noted that the call isn't just have docs and nurses after they've already put in more than a day sit at the bedside. But what kind of advice might you have, suggestions, reflections for the future medical students, nursing students, and health profession students who are on the call now in light of community?
So there's two ways to address that question. The first way is, well, I'm a dying person too. I mean, I have no terminal illness that I know of, I'm in good health, blah, blah, blah. But like, we're all dying, right? We're all sort of slowly marching toward the inevitable, right? And so therefore, as someone who is living with a view to the end, I need to cultivate my own community. One of the exercises I often have people do is think about who you would want at your deathbed, right? I mean, students, they're kind of thinking about who they want at their wedding at this point, but think about who you would want at your deathbed, and then work backwards and assess what is the state of those relationships now, and what do I need to do to invest in those in those people so that we are together, kind of moving forward together. With whom do I need to reconcile? What's the issue at stake there? How can we work this out? I had somebody once ask me in a Q&A, he said, I know who I want at my deathbed, but frankly, I can't stand them. And what do I do about it? Can't I just wait? And the question, my question and response is, well, do you know when you're going to die? I mean, none of us does, right? So if you wait, there's a chance that he won't be at your deathbed, but there's also going to be this lost opportunity of years of lost relationship. And so this is where the living well and the dying well link. But then as future doctors, nurses, caring for patients, these are actually conversations I have with my patients. So everything I just said to you, I say to myself, I would say to my patients. And in fact, the reason why I wrote the book, I didn't write this particular book. I have an academic book, but I didn't write this particular book for professionals. I wrote it for my patients, so that my patients, even now, while they're, they've got their wits about them, they're in good health, they can be planning, thinking about, anticipating their mortality, and then working to prepare for that.
Thank you, Lydia. That's wonderful, and I think is the perfect end to what's been an engaging question and answer session, and really a wonderful talk. I mean, the breadth, as I said before, of history and medicine, with the infusion of philosophy. I mean, it's given, I know, me and I'm sure everyone else on the call so much to think about. So thanks to everyone for joining, and Professor Dugdale, everyone I know would be applauding, but we've muted them. So we'll sort of, we'll feel the applause. Thank you for listening to this episode of the COVID Ethics Series podcast. Be sure to check out video versions of our episodes online at library.shu.edu/COVID ethics. Follow the show on Twitter at SHU Bioethics, and our moderator, me, at BCP Ethics. And if you're listening to this show on iTunes, Spotify, or wherever you get your podcasts, please subscribe and leave a review. If there's a topic you'd like to see discussed in the future, let us know.
The COVID-19 vaccines were developed and tested within stringent guidelines from the U.S. Food and Drug Administration. That this happened faster than usual is due to the urgency of this pandemic and the extraordinary collaboration of dedicated scientists around the world.
Hear more from New Jersey doctors about COVID-19 at nj.gov/health/vaxfacts. That's nj.gov/health/VAXFACTS.
Remember before COVID-19, when we could go to shows or celebrate in person or have family gatherings where the only worry was when someone was going to talk politics? Let's get back to that. Let's get vaccinated. COVID-19 vaccines are safe, effective, and free. Sure, we'll have to keep wearing masks for a while, but you know what? This is the start. Go to covid19.nj.gov/vaccine to register for your vaccination. Remember traveling somewhere? Anywhere? Yeah, let's get back to that.